When we come to the skull of the horse, certain structure that you need to pay attention to. First, let us go through the bones of the skull and the facial bones. Starting with the most rostral, this is the incisive bone. This is the nasal bone. Over here, this is the maxilla or the maxillary bone. This is here is the zygomatic bone. This is the frontal bone. This is here is the parietal. This is the dorsal, sagittal. This is the temporal bone here, and as the most caudal aspect is the occipital bone. So the bones are very similar to the one that we have seen in the dogs and in the cat. An area that needs attention because it is different in the horse, that the orbit in the horse is the complete rim. The rim of the orbit is complete in the horse, which is different than the one that we have seen in the dog, where the caudolateral aspect is filled with the orbital ligament in the dog. In the horse, the orbital rim is a complete cup. Another structure that also differ in the horse is the presence of this foramen here. This is the supraorbital foramen. And the supraorbital nerve, which is a sensory nerve that is coming from the frontal and the frontal is coming from the ophthalmic. This is a sensory nerve to the upper eyelid from the outside and from the inside, and to the skin at the level of the frontal bone. By the way, this process here, this is the zygomatic process of the frontal bone. And at the junction of that process and the frontal bone, that way you locate the infraorbital foramen. Another foramen is the infraorbital foramen. And the infraorbital foramen is an important structure in the horse because it's a palpable structure. You can palpate this in the live animal. And you can utilize this when you do infraorbital nerve block. The infraorbital nerve is a continuation of the maxillary nerve, which is cranial nerve number, one of the branches of cranial nerve number 5, the trigeminal. The infraorbital will come out through the infraorbital foramen, and that is where you can block it. And you do that blockage because the infraorbital nerve go and provide sensation to the upper lip and to the lateral aspect of the nose in this area here. So if you want to do any minor procedure at the upper lip, if you want to suture a cup or something from that sort, you block the infraorbital nerve as soon as it's coming out of the infraorbital foramen. Another structure that you need to pay attention to is the facial crest. And you will utilize this the rostral aspect of this facial crest together with the naso-incisive notch, this notch here in between the nasal bone and the incisive bone. This is the naso-incisive notch. Okay, if you draw a line from the naso-incisive notch to the rostral end of the facial crest, you will realize that the infraorbital foramen, it is just caudal to the midpoint of that line. Okay, once you can palpate the naso-incisive notch and the rostral end of the facial crest, you will be able to locate and palpate the infraorbital foramen. Okay. Another structure that involves the horse head is the sinuses. And the sinuses of the horse is very important because it is an area of clinical applications and clinical implications and clinical cases. And starting with the conchofrontal sinus. which actually consists of the frontal sinus and the dorsal concave sinus. But because these two are connected completely with each other, they consider them as one large compartment. They refer to it as conchofrontal sinus. Deep to the maxillary bone, there are two sinuses. There is the rostral maxillary sinus and the caudal maxillary sinus. And these two are separated with this bony septum. They are completely separated, which means there is no communication between the rostral maxillary sinus and the caudal maxillary sinus. So the normal drainage of the sinuses goes like this. Okay? Drainage goes from the conchofrontal sinus and through an opening between the conchofrontal and the maxillary. This is the frontal maxillary opening. That leads to the caudal maxillary sinus. Okay? And the conchofrontal and the maxillary sinus communicate with the middle nasal meatus, and that's how the drainage from the sinuses go through the nasal cavity to the outside. Okay? I want to draw your attention here to the extension of the cheek teeth inside the maxillary sinuses, and this is especially for the molars, will extend with age. Horses, they have hypsodont teeth, which means their teeth continue to grow throughout the life of the animal. And in old horses, the root of the teeth invade the caudal maxillary sinus. And in this case, you can utilize trephination through the frontal sinus, okay, to bunch and hammer the tooth out through a hole you do in the frontal sinus. Also, you can access that through the maxillary sinus, and also some vets they utilize the oral cavity proper to do that. In horses, the temporomandibular joint is not a highly movable joint. If I put the joint here, okay, the temporomandibular joint between the condylar process of the mandible and the temporal bone, this joint is not highly movable joint in the horse. That means the horse is not able to open their jaws wide, so you can fit your hand there and extract any diseased teeth over there. Although it's an option that you can utilize if you prefer to go that way. Now, this will lead us to the discussion of the mandible. And the mandible of the horse is huge. It has a ramus and it has a body. Okay? On the rostral aspect of the body, there is the mental framing. And the mental framing, the mental nerve comes out through this mental framing to go and provide sensation to the lower lip. The mental nerve is the branch of the inferior alveolar, and the inferior alveolar is the branch of the mandibular nerve of the trigeminal. At this level here, on the medial aspect of the mandible, this is the mandibular framing. At this level here, the mandibular nerve will give the inferior alveolar branch that runs through the mandibular canal. At the level of the mental framing, it gives this mental branch that comes out and go and bring sensation from the lower lip. And the inferior alveolar will continue to provide sensation to the canine and the incisor teeth with their gums. So if you want to do any minor procedure at the level of the lower lip, okay, you block the mental nerve as soon as it comes out of the mental foramen, and you can palpate the mental foramen in the live animal. Now, going back to the mandible, okay, there are two processes. This is the chronoid process of the mandible. This is the condylar process of the mandible that articulate with the temporal bone to form the temporomandibular joint. And this notch here in the mandible, they refer to it as the vascular notch. And this is where you can feel the pulse in horses. Okay? The facial artery run here together with the facial vein and the duct of the parotid salivary gland. You can feel the pulse at the level of this vascular notch. So also bear that in mind. We're going to see this structure when we go through the dissection of the muscles and the other structures of the face. Going to the ventral side of the skull, we have the occipital bone all the way up to this level here. Okay, then we have the sphenoid bone, and then we have the trigoid bone, and we have the humulus of the trigoid bone, and we have the vomer bone, which is here. This is the vomer bone, and this is where the nasal septum sits. This is represent the base of the nasal septum. Okay, over here, this is the palatine. This is the palatine bone. Okay, and here this is the maxillary. These are the incisive. These are the incisive fissure. Okay, and now a clinical application you do at the level of the sinuses is trephination. And trephination of the maxillary sinus, there are certain boundary that you don't go beyond or you don't violate. Okay, so your ventral boundary is the facial crest. The dorsal boundary is the line from the orbit to the infraorbital foramen, and the rostral border is the line from the infraorbital canal to the rostral end of the facial crest. So this square here is where you do your maxillary trephination. For the frontal, you can do it here, okay, where we do the circle here. This is where you do trephination of the frontal sinus. Again, this is the supraorbital foramen, where the supraorbital nerve is coming out, and you block that nerve for examining the eye. It's a sensory nerve to the upper eyelid and to the skin in this area over here. Now let us go and simulate the structure that we can palpate in the live animal, and starting with the facial crest. This is a facial crest here. It's a palpable structure. You can palpate it, and this is the rostral end of the facial crest. On the other hand, the nasoincisive notch is here. Okay, you can feel the nasoincisive notch. This is here. This is the infraorbital foramen. And remember, when I said earlier, is that when you draw a line, okay, when you draw a line, okay, from the rostral end of the facial crest to the nasoincisive notch, at the just caudal to the midpoint, that you can locate the infraorbital foramen. On the orbit of the eye, you can palpate the whole orbit, because we said the orbit rim is complete. And at this level here, you can feel the supraorbital framing, and that is where you do your supraorbital nerve block. At the mandibular frame, at the infraorbital framing here, you do the infraorbital nerve block, and down here, okay, you can feel the mandibular framing. You can see the mental framing, I mean, where you can block the mental nerve. Now, if you want to do a mandibular alveolar nerve block, okay, and you do that at the level of the mandibular framing on the medial aspect of the mandible. And actually what you do, you draw a line from the lateral conus of the eye down, okay, and you draw a line from the occlusal surface of the cheek teeth. The occlusal surface is where the upper cheek and the lower one meet. So if you draw a straight line from there, the point where that line intersects with the line that you draw from the lateral aspect, that point, the mandibular framing is approximately at that level. Okay, so you measure the distance from here up to the mandible there, and this will give you the length of the needle that you're going to utilize, because you're going to insert the needle on the medial aspect of the mandible. So you draw these two imaginary lines, okay, where they intersect, okay, that will give you approximation of the location of the mandibular framing from the medial side of the mandible. So you measure the distance from here up to here, okay, and this will give you the size and the length of the needle that you need to use. You insert the needle from the medial aspect, okay, and usually you do that and you mark your needle, okay, so you know where to stop when you are inserting your needle, and once you reach that mark, you stop and you dispense your anesthetic agent. So now, once we reflect the skin from the face, we are looking at the superficial structure. We can see the masseter muscle is huge muscle here. We can see the levator nasolabialis. We can see the levator labii superioris that will run in between the two nostrils to go to the upper lip, and that is the muscle that you need to move away from your side to feel the infraorbital nerve. Also, you will see the dorsal and the ventral buccal branches of the facial nerve. These are motor branches to the muscle of facial expression. It goes to the buccinator muscles and all these levator labii and levator nasolabialis. Okay, so this is the dorsal branch of the buccal nerve. This is the ventral branch of the buccal nerve. I want to draw your attention to this structure run here. We have a vein, we have an artery, and we have a nerve. These three structures here. Okay, this is the transverse facial vein. This is the transverse facial artery, and this is a branch of the auriculotemporal, which is coming from the mandibular. This is sensory to this area here, but this three structure runs together, and the transverse facial artery sometimes could be utilized for pulse taking, and the transverse facial vein sometimes may be utilized for venifunction. Okay, although the major artery for taking the pulse in the horse, it is the facial artery, which is this one over here, and I said earlier when we cover the bone structure that as the vascular notch of the mandible, you can feel the pulse at that level, and that is, you feel the pulse from the facial artery. The facial artery is accompanied by the facial vein, and this structure here, okay, the most rostral one, this is the parotid duct. And now you realize that the parotid duct runs on the ventral aspect of the mandible, okay? You remember in the horse, the parotid duct runs in the middle of the masseter muscle. In the horse, is completely different. The parotid duct run on the ventral aspect of the mandible. This is the parotid duct, okay, which is the duct for the parotid salivary gland. At the level of the vascular notch, it accompanied by the facial artery and the facial vein. And the facial artery, this is where you take the pulse in horses. Bear that in mind. I want to draw your attention to the huge parotid salivary gland. It extends all the way from the base of the ear and the atlas all the way to the mandible. So it's huge. Now, this structure here, medial to the mandible, this big and huge lymph node, this is the mandibular lymph nodes. There are two, one on the right and one on the left. They occupy the intermandibular space. They form like a V shape. And when this lymph node get inflamed, that's what we call strangles, okay, which involve infection and inflammation of the mandibular lymph nodes with other lymph nodes in the head. Again, another specimens, just to show some of the structure that we mentioned. This is the masseter muscle. This is the levator nasolabialis. This is the buccinator muscle. This muscle here, this is the levator labii superioris, and you can see the tendon goes and runs in between the two nostrils to go to the upper lip, okay? And when you move the levator labii superioris out of the way, that will expose the infraorbital nerve, okay? This is the infraorbital nerve. It's a bundle because the nerve, there's an artery and vein runs with this, so you will feel a bundle. But when you come to do your block, you have to move the levator labii superioris either up or down and feel this bundle here, and so you can feel the infraorbital framing, and then you do your nerve block. At the ventral aspect here, okay, this muscle you see here, this is the depressor labii inferioris, and this is the muscle that covers the mental framing, and this is the muscle that you need to move down to be able to feel the mental nerve, which is this nerve here. Okay, this is the mental nerve coming out of the mental framing, and that is where you do your mental nerve block. Another structure worth mentioning at the floor of the nasal cavity, at the junction of the cutaneous zone with the mucosal zone. This is the area where you can find the opening of the nasolacrimal duct, okay, at the mucocutaneous junction. So if you see this slit here, this is the opening of the nasolacrimal duct. I'm going to insert the probe inside, and I'm going to open here so you can see it. You can see it better. Okay, let me focus the camera a little bit so you can see it in a better way. Okay, so this is the opening of the naso-incisive duct, okay, at the floor of the nasal cavity at the junction of the cutaneous area with the mucosal area. Now, when we come to the medial aspect, okay, here we see the nasal septum separating the nasal cavity into a right and left nasal cavity. Okay? This opening here represents the choana. This is the opening from the nasal cavity to the nasopharynx. This structure here, this is the hard palate. Okay? You can see the transverse ridge. Okay? And this structure here, this is the soft palate. And the soft palate of the horse is very long, as you can see. And this makes it very hard to do orogastric intubation in horses. That's why in horses you have to do nasogastric intubation, because orogastric intubation, the tube will hit a dead end that is formed by the long and elongated soft palate. Okay? Now, another structure here, this is the ethmoidal concha. This sinus here, this is the this is the sphenoid sinus, and the sphenoid sinus is in communication with the conchofrontal sinus. Bear that in mind. Down here, we can see the epiglottis. Okay. We can see the laryngeal ventricle. We can see the vestibular fold. We can see the vocal fold. We can see the cricoid cartilage, and we can see the cricoarytenoideus dorsalis muscle that when it contracts, it will abduct the vocal fold, which is over here. Okay? And when this muscle gets paralyzed, that will lead to laryngeal hemiplegia, because this vocal fold will paralyze and become lax and sit in the middle of the laryngeal ventricle, obstructing the air going in and out. Now, if we remove the nasal septum, okay, that will reveal the concha. And the concha is bony scrolls, okay, coming from the maxillary bone and covered with mucous membrane. This is here is the dorsal nasal concha. This is here is the ventral nasal concha. This is the alar process of the ventral nasal concha, and that is the basilar process of the ventral nasal concha. The spaces between these concha is the meatus. We have the dorsal. Now, let us look in more detail to the area of the larynx. This is an area of clinical cases and clinical procedure. Okay, this is the soft palate for your orientation. Okay, this is the nasopharynx. This is the pharyngeal opening of the auditory tube. This is the epiglottis. Okay. This is the arytenoid cartilage. Okay. This is the corniculate process of the arytenoid cartilage. Okay. This is here is the arytenoid cartilage, and this is here is the cricoid cartilage. Okay. If you want to look at it here, this is the ventral part of the cricoid cartilage. This is here is the thyroid cartilage, and this is the laryngeal ventricle. Okay. This is the vocal fold. This is the vestibular fold, and this is the epiglottis. Okay. This muscle that you see here, okay, let me lift it here. This is the cricoarytenoideus dorsalis muscle that gets paralyzed when the left recurrent laryngeal nerve or the left caudal laryngeal nerve get injured. This muscle gets paralyzed. That lead to the paralysis and lack of the vocal fold that leads to laryngeal hemiplegia. In the tie back procedure, you have to make a tie between the cricoid cartilage and the muscular process of the arytenoid cartilage, and this is here is the muscular process of the arytenoid cartilage. Okay, you can feel it, okay? It's a tough structure. So this structure here, this is the muscular process of the arytenoid cartilage. So in the tie-back procedure, you make your knot in between the cricoid cartilage and the muscular process of the arytenoid cartilage. Okay. Another structure here, okay, this is the thyroid cartilage, and this is the arytenoid cartilage. This ligament here is the cricothyroideus ligament, okay? And once you go through this ligament, it will give you access to the laryngeal ventricle. So bear that in mind. It is on the ventral aspect. It's a ligament in between the cricoid cartilage and the thyroid cartilage. It is this ligament here. Okay, this is the cricothyroideus ligament or the cricothyroid ligament. When you cut through here, it will give you access. You are inside the larynx.